Good morning to Chairperson, panel members, my advisor, industry partners, and ladies and gentlemen. Thank you for coming. Informal long-term care, informal caregivers, subjective well-being, and service utilization. There are 5 parts to my presentation this morning. Part 1 shall describe the role of this thesis research, which led to the aim to elucidate the role of informal caregivers' subjective well-being in explaining formal long-term care service use. Part 2 shall report on Study 1, which conceptualized informal caregiver subjective well-being as constructs of caregiver psychosocial needs, and ask if these needs are associated with formal long-term care use, or LTCS. With stroke rehabilitation as a LTCS type of long-term care, Study 2 in Part 3 used the subjective well-being construct as caregiver well-being attributes and asked if the latter predicted service use over time. Study 3 in Part 4 understood the subjective well-being construct as caregiver psychosocial health profile and asked if these profiles predicted service use over time. In Part 5, finally, I shall summarize the findings and describe contributions of this thesis research. Let's go to Part 1. Population aging is a global phenomenon, as most of us know. Virtually every country in the world is experiencing growth in both the size and the proportion of older people in the population. In 2019, there were 703 million persons aged 65 or over in the global population. This number is projected to double to 1.5 billion in 2050. Globally, the share of population aged 65 or older increased 6% from 1990 to 9% in 2019, and this proportion is projected to rise further to 16% in 2050, when it's expected that 1 in 6 people worldwide will be aged 65 or older. In Singapore, in 2015, 1 in 8, as you can see, that were aged 65 or older. That's about 400,000 citizens. In a decade's time, this number is projected to double to 1 in 4, or almost 900,000. The graying phenomena has come about due to trends of falling birth rates, widening gaps between life expectancy and healthy life expectancy, and chronic illnesses replacing acute conditions as causes of disabilities and premature deaths. The location where older adults receive long-term care services has evolved over the years. The World Health Organization noted a shift among its member countries from traditional hospital-based long-term care to community-based long-term care for older adults. In many countries, as with Singapore, formal long-term care service, which are services provided by health or social care professionals, is broadly categorized into institution-based, home-based, and center-based care. Besides formal care, we know there is informal care, which is services provided by an older adult's family members, relatives, friends, neighbors, or even foreign domestic workers. These informal caregivers usually assist an older adult on a variety of tasks, from dressing to bathing and even to feeding. Despite an increasing need for formal long-term care services, the utilization rate is low or declining in many parts of the urban world, such as the 67% drop in residential long-term care service use in the Netherlands observed from the year 2000 to 2008. In Singapore, as you could see from the statistics released last year by the Singapore Ministry of Health, center and home-based care utilization rates are far from optimal at the moment. The Anderson behavioral model of health services use is an established theoretical framework by which to understand the reasons that an individual holds in using or not using health services. This model is based on data collected by national health surveys in the United States since the 1960s and has focused on acute and primary care services. It has only been more widely applied to understand long-term care use in the past 2 decades. In my research, I focus on individual characteristics, boxed up in red over there, of predisposing, enabling, and need, and their association with use of personal health services. Based on systematic reviews and meta-analysis, there are 4 main deleterious effects of informal caregiving. Firstly, socio-demographic risks, such as low income, lower education, older age, spouse of the care recipient being female, and living with the care recipient have been known to be risk factors associated with informal caregiving. Then we have the caregiver's perceptions of the care recipient's physical, psychological, and existential suffering as another risk factor. There have been reports that informal caregivers care for their loved ones, older loved ones, out of guilt, shame, or even sympathy. Then we have caregivers' health and physical functioning on the decline. Poor self-rated health, stress, having 3 or more medical conditions, poor sleep, poor appetite, loss of weight, pain, and so on have been reported among informal caregivers. And finally, we also have a caregiver's social and professional support being limited. Things like statements like no one to help with caregiving, no one to talk to, no time to socialize with others, no access to use of professional care services have been reported by informal caregivers. The foregoing trends bring us to a conundrum. On the one hand, if informal care is designed to provide that which is necessary for the patient, but which could not reasonably be expected from informal caregivers, like family and friends, why do we continue to observe adverse health and social outcomes associated with informal caregiving? On the other hand, if the established Anderson model helps long-term care service designers understand utilization factors, why are the usage rates still far from optimal? So this conundrum implicates public policy. Should more public monies be spent on supporting informal caregivers? Would the monies really help informal caregivers better care for themselves and their loved ones? Or should these monies be used to spend on to build more long-term care, long-term elder care facilities and services? Would these facilities be used effectively? Taking a community geropsychological approach to address this population health phenomenon, my research aims to make clear the role of informal caregiver subjective well-being in explaining formal long-term care use. With a systematic review and meta-analysis of literature, Study 1 attempted to synthesize the available knowledge on the main topic. Then, using a data set obtained from stroke survivors and their informal caregivers, Studies 2 and 3 attempted to uncover determinants of formal long-term care service use among subjective well-being attributes and profiles of informal caregivers. I did logistic regression and latent profile transition analysis, respectively. The findings of this research would first contribute to the understanding of long-term care use factors, second, inform integrated care theory on the nature of care, and third, guide the design and delivery of care integration.